morning everyone. Today we're gonna read about psychiatry, and we'll start with how to assess the mental state, or we'll say mental state examination. So what are the main points that we should consider? First of all, we should see generally you see appearance, behavior and attitude the patient has towards the examiner. Appearance, we can see if he's well groomed or poised, have good clothes. Body type, is it disheveled or neat or childlike? And behavior, if it is restless or he has any tics or he is calm. And attitude, is it frank or is it seductive or is it cooperative? So from general description only, like if the patient is disheveled, he may be it may lead to the thinking of being in psychotic state, where the person is not able to take care of his or her appearance, and can also be a differential diagnosis for schizo. And it can be the person is if he's or she is feeling cold, it may point towards hypothyroidism. So it's not like something very, but it helps us very diagnostic, but it helps us to give an idea of the condition of the patient. So next we can see mood, affect and appropriateness. So mood is emotions perceived by the patient, whether he looks depressed, anxious or angry, whatever he feels. And affect is what the patient present with the emotional responsiveness, like he is showing any emotions or not, he has blunted emotions, like shows less emotion, or he is completely flat, no emotion at all, or he is very labile. So that, and mood, that's the difference between the mood and affect. So it affect shows the emotional responsiveness. Now appropriateness, if there is in context, there is appropriate, inappropriate, whatever we feel like. And speech, we have to see if he's it's relevant, or he's in under the pressured speech, which is in mania. And is he fluent, is his comprehension okay? And then we can go for the perceptual disturbances, that is the experience in reference to the self or the environment, like hallucinations, illusions. Hallucinations are false sensory perception but with no stimuli. Illusions are sensory misperception with a stimuli, like a rope will be there, but it will appear like a snake, so that is an illusion. There is a stimuli. Hallucination, any kind, like visual, there is nothing there but you will still see the object. There is nothing, no one speaking, you will still hear it. Auditory hallucination, so there is no stimuli in hallucination. So auditory hallucination mainly is very common in psychotic disorder. Visual is very common in Lewy body dementia, drugs, or any organic disease. Tactile is very common with cocaine intoxication or alcohol withdrawal. Olfactory is very important with the seizures, and mainly with the temporal lobe epilepsy. So that's how these things, the general description we give of patient helps us. Next we can see the thought patterns. What is the form of the thought? The way in which the person is thinking, is flight of ideas, or there is loss of association, or is tangentiality, he touches the topic and just touches it and moves away from it, or there is circumstantiality, he is just going round and round and round around the topic, beating around the bush but not coming to the point. And in mania there is flight of ideas. And now content, and other part of thought is, this is the form, other part of thought is content of thought, when the person is actually thinking about like delusion, paranoia and suicidal ideas. What is he thinking about? So there is form and there is content of the thought. Now there is something called sensorium and cognition. So in this we see alertness and level of consciousness. Is the person oriented to time, place or person? So alertness, orientation, time according to the time, place, person, memory, if he or she has intact memory of recent, remote, recent past, and they have immediate retention and recall, concentration and attention. Like we can do serial 7, that is 100 minus 7 or up to 5, and if he or she is able to do that, or there is ability to spell backwards, we can use for this. And then there is capacity to read and write. We'll ask the person to read the sentence and perform what it says. And visual spatial ability, like copying a figure, and abstract thinking, like similarities in proverb interpretation. So it is mainly lost in schizophrenia. And fund of information and knowledge, like calculating ability, naming the past president. So these helps us in knowing about the sensorium and the cognition of the patient. Now we'll ask for any history or behavior of impulse action, or there is too much impulsiveness, and how the patient acts, if he or she acts appropriately and they are able to reflect it on their self. And then there is reliability, what is the physician impression of the patient ability to accurately assess a situation, whether or not he is able to do that, that is reliability. So these are all the part of the mental state examination that we do. And now there is something called how to interview a patient. So there can be many interviewing techniques in psychiatry. So interviewing the techniques is, first of all, we'll use open-ended questions. Open-ended questions is you have to allow the patient to tell in his own words as much as possible. So like ask, can you describe your experience, can you describe your symptoms. And then there is something called closed-ended questions, like we want specific information, but without allowing options in the answers. So it is very direct, like are you hearing the voices, are you seeing the people, are you feeling some bugs on you, or like that. And then there is facilitation. In this, we help the patient to continue by providing verbal and non-verbal cues. So in this, what we are, if the patient is telling something and we wanna ask, and we'll say, please continue. Yes, please continue. So that we are asking the patient to continue, describe it, and give us. So we are helping with cues, sometimes nodding, and that is the non-verbal cue. The next is confrontation type of technique. We are pointing someone about their, like you seem very low, and you seem very excited, you seem like that. And then there is leading, that we are leading the answer in the question, we provide the answer in the question. Like in schizophrenic patient, if occurs and he, or any psychotic patient, he is having auditory hallucinations. So we'll ask, are these voices telling you to hurt yourself or telling you to hurt someone else? But so we are providing the answer, he just has to confirm it. So that is interviewing type. So it can be open-ended, it can be closed-ended, it can be facilitating, it can be confrontation type, and it can be leading type. So for some example, if we go through, if just suppose there is a young person who comes with a complaint of auditory hallucination for some months, and he is saying that I'm hearing voice of my family members, and sometimes the male, sometimes female, and he is distressed and he wants help. So what would we say to him? What will be the first statement that we will say to him? What kind of interviewing you will do? So in this particular scenario, we would like to go with an open-ended question, and we'll conclude with a closed-ended question. So we'll ask, can you describe your experience? Can you describe what voices are saying to you? Can you describe what did you see? And then we can end it with, are they telling to, are you really hearing them? And what are they telling you? So the best answer in this case scenario is, tell me about the voices. So that's how we go with it. Okay. And other, we can see, if there is a suppose young female, she comes to you and she's in She has been grieving her mother death, which has been less than 1 month, and she has low mood and she feels helpless. And while she is there in front of you, she starts to have an emotional burst and she starts to cry. So what will be the next step you will take? What you will say to her? So first of all, we should always start with such patients with empathy, and we should give them the control of narrating their own story. And by how we'll do that, we'll stay in silence. We'll offer them something like tissue or some water, and this will help them feel to be in safe environment. So then what we'll do, we can in this case we can refer her or her to the psychiatrist. So that will be the best case scenario, uh, to see the severity of the symptoms. Is it normal grief? How to process it? How we can use different therapy, or if any medication is, if it is a case turning into MDD, major depressive disorder, any medication required. So that will be decided by the psychiatrist. Now in psychiatry we have something called defense mechanism. Sorry, I'll have some water just a minute. Now in psychiatry there is something called defense mechanism. See, this is all for USMLE step 2, not for any just for USMLE step 2, very crisp and very important topics of the psychiatry. And we'll do ethics also in the next video, because that is also a very big part of USMLE curriculum, and that is not being covered in mostly in other states or other countries, mostly examinations. So defense mechanism, what are they? So this is a way and way where the ego in a person wards off anxiety and control instinctive urges and unpleasant emotions. So they are unconscious. So be very clear with that. They are unconscious, except some like suppression that is conscious. If we suppress some feelings inside, they are unconscious, they are discrete, they are dynamic, and they are irreversible. And they can be adaptive as well as maladaptive. Okay, so that is our defense mechanism. It's the way that our ego lets off anxiety and control instinctive urges. So let's see, some are immature and some are mature defenses. So we start with the immature defense. First we have projection. So projection is we are attributing our wishes, our thoughts and our feelings into someone else. So if a person is feeling that he's cheating or something, so he'll say my wife is cheating on me. He's projecting his own fear into the action of her wife. Then there is something called denial. So this is practiced by some patients mostly to become unaware, that they don't want to be aware of the painful reality. Like if they have been diagnosed with cancer, they will know it's not. If some death has occurred nearby, they will be in denial. So it's a way to escape the painful reality. Now next is splitting. Splitting is very common in type B personality, borderline personality type, in which there is everything is good or everything is bad kind of situation. So there are only extremes, there is no middle ground. So mainly they ask this question a lot. So borderline personality disorder. So like a female patient comes and she says the staff is very bad, they are not treating, and suddenly doctor comes treat her, the doctor is too good. So either everything is good or everything is bad. And like a female tells about a boyfriend, like he is the best boyfriend in the world, she'll be obsessed about him and all that. And then suddenly after some very small argument, and he is the worst, and There is no one worse than him in the world, so that kind of extremist. Next is the blocking. This is the temporary block in the thinking. You know someone from years but you forget his or her name, so it's like being blocked. And then the other type of defenses like regression, very common. Regression is we go to the early stage of development, which are when we were kid. So so like a person who is undergoing a very harsh breakup, and he starts to wet his bed like very again, like he used to do when he was a child, or the child of a divorce. He has been dry for so many years, but since the parents are splitting, it's very, it's too much stress for him, when he starts to regress to his old bedwetting habits. The other thing is somatization. Somatization is something like the psychic derivatives are converted into bodily symptoms. So whenever we think of an examination, like we have examination tomorrow, we will be like, oh, my stomach is having so many butterflies, I'm not feeling. You'll go to washroom so many times, and it will be like you will have a very funny feeling in your stomach. So that kind of, so the symptom, the thought in your head transferred, it's like thought in your head is transferred in your body, and the entire body is in anxious state. So that is the somatization of the symptoms. And then there is introjection. Introjection is features of external world are taken and you have made them part of yourself. So a person like a person who likes to idolize his seniors, and they start to speak and dress like them, so they have made him as part of his own self, and that he admired. And so that is introjection. Other is displacement. From the name itself we can see displacement. There is emotion is shifted from one person to the another, and the real reason is the first emotion in the place. Like a boss is shouting on all his employees, but previously he had a very bad fight with his wife, and he has displayed all his anger to all the employees. Now then there is something called repression. Now repression is an idea or feeling which we withheld from the consciousness. So it's like unconscious forgetting. And like a person who was very attached to his or her dog, and now the dog is not there, and then he, after some time, he says, I do not remember having had a dog, because he has repressed that part and from his consciousness. And it is like unconscious forgetting. I said suppression is consciously suppressing any particular memory that makes us uncomfortable. Repression is unconscious. Now something very important in all the medical students are intellectualization, or any person with a higher education mostly practice this. Like suppose if a doctor is diagnosed with a cancer, and he says, okay, it's a stage 3 cancer, it's stage 2 cancer, we can do this drugs, and then I'll be well after some time, then we can go for the chemotherapy and it will be all right. And he's just intellectualizing the whole scenario instead of taking diagnosis and letting his feeling of sadness to surface. So he doesn't allow that, and he intellectualizes the entire thing. It's mainly to avoid the affective expression in the experience. Now something is called isolation. So isolation, we separate the idea from the affect which comes with the idea. Like a person or a mother who's asked to identify his son body in mortuary, so she comes and identify, but she shows no emotion over it. So what she has done, she has separated the idea from the effect. So she's not letting the emotions to come on the surface, and that is called isolation. Then something is called rationalization. This occurs in a lot of alcohol drinkers. They will rationalize their drinking habit by saying they are very much stressed at the home. Their father used to drink and beat his mother, and they will give all the explanation to justify why they are alcoholics. That is the acceptable attitude or beliefs. And someone saying, I did not pass the test because the test was harder this time, although they didn't prepare at all. So that's, and something other thing called reaction formation. And very unacceptable impulse is transformed into the opposite. So suppose there is a, it's like it results in the very formation of the character traits. So example, listen to him tell his family he was not afraid when I saw him crying. So he was afraid, but he didn't show it, and that's the thing. He has made an opposite reaction, like he is very brave, and he doesn't let his, his real emotions to be seen. Now undoing something, this is what most rich people try to do, or very mafia or bad people try to do. They try to justify their bad things they have done by making large donations, and they are acting out the reverse of an unacceptable behavior. Like suppose a person, if he or she has very bad thoughts, he or she will say that I need to wash my hands whenever I have these thoughts, and they feel like it will undo all the thoughts that are coming. So the unacceptable behavior, so acting out the reverse of an unacceptable behavior, like an act. And then something is called acting out, like behavioral or emotional outburst. So now, especially in the children of divorced parents, they are always accused of acting out because they are under stress and pressure, and they tend to act out, and they start to get in trouble right after the separation because of it. Then there is very mature defenses humor that we see nowadays. It permits the expression of feeling and thoughts without personal discomfort, because everyone has a good laugh about it. So this is part of mature defense. Now other mature defense is sublimation. Sublimation is like a person who likes to cut things, he becomes a surgeon. So he is allowed his instincts to be channeled in something which is more acceptable in the society. So the impulse gratification has also been achieved, and but the aim and object is different. So he wants to cut, he got into being surgeon. Now he can satisfy his impulse, as well as he has channeled it into a better way of society. So it is one of the most mature of the defenses. Now something called suppression, that I've told you, that is conscious forgetting and conscious defense mechanism. And like if we are waiting for let's say for USMLE, let's say we are waiting for an exam result to come. So it makes us anxious and miserable. So I'll consciously forget it. It's okay, I don't want to know, it will come on its own time, I don't want to think about it, that kind of thing. Then there is something called dissociation, that is splitting of the brain from the conscious awareness. So I hardly remember getting it to the hospital after my husband was hit by a car. So that is dissociation, the splitting of the brain from the conscious awareness. So next, these were the different types of defenses. So what we can say, the mature ones: sublimation, suppression, humor, and the immature ones: the displacement, introjection, somatization, regression, repression, intellectualization, isolation, rationalism, reaction, and the undoing. Next, we can discuss about some of the tests that we know, like IQ test, which is intelligence test, and it measures academic performance in relation to the mental age and the chronological age. So, what is mean IQ? Mean IQ is around 100 with a standard deviation of 15. So, IQ is calculated by mean age upon chronological age, mental age upon chronological age into 100. So that is in case they can put a numerical on it, or they can ask for the formula. That's why in adults mainly we used Wechsler Adult Intelligence Scale, revised one. And in children we use Wechsler Intelligence Scale for children revised. So that is the difference. Now we have some tests to check the personality. So first of all, personality test. So one is objective test. In this we use the simple stimuli, and we see the reaction, and this doesn't require very much clinical experience, and it's mainly done with Minnesota multiphasic personality inventory. Now other is this is objective, then there is projective test. In this there is ambiguous stimuli, and we give the ambiguous stimuli and we see the reaction. Like in Rorschach test, we give, suppose, a picture of a bat, and we ask the patient what does he see, what does he feel about it, what is it. And like thematic appreciation test, Rorschach test, and sentence completion test, we give some family drawings and ask the patient what does he or she see in the painting, and what does all the feelings about it. So it can be objective, projective. Objective mainly includes Minnesota multiphasic personality inventory, and the projective ones are very commonly used: Rorschach, that is ink plot, thematic appreciation test, sentence completion test, and family drawing. You can Google some images of the Rorschach test that are very interesting. So that will also help you build the interest in, help in revising and remembering it. So next very important thing that we're going to talk today is intellectual disability. So what is intellectual disability? Formerly it was called mental retardation, but now it is intellectual disability, so don't use the term MR. So it is mainly below average intellectual function, and like IQ less than 70, and it is measured by various IQ tests just we discussed, and it is accompanied by the concurrent impairment in adapting to the demands of the school, at work, at social and environment, and the other places. And the intellectual disability is usually manifested in people less than 18 years of age only. It starts. Now, what can be the risk factor for this? We have studied so many chromosomal abnormalities and genetic disorders which present with the intellectual disability, that are due to inborn errors of metabolism like lipidosis, amino acidureas, glycogen storage disease, and like chromosomal abnormalities like Cre-Du-Chat, Down, Fragile X. So they are all associated with intellectual disability. Other thing that can be infective can be rubella, CMV, other, and there are toxins or drugs like alcohol, and there is some conditions like hypoxia and malnutrition that can lead to it. And postnatally, patient can get exposed to toxin and infection. There can be, like, there is no prenatal care taken, there is no postnatal care taken, and he or she has been exposed to some heavy metals, or there is some physical trauma that has occurred, or the patient is deprived of the social environment that is required by every kid. So these are the various causes why the intellectual disability can occur. Now it can be divided into three categories: mild, moderate, and severe. Say mild is around IQ is 50 to 69, moderate is 35 to 50, and below 20 is severe intellectual disability. So in the mild case, the patient achieves the academic skills and he is able to go till fifth, sixth grade independently, and he can live independently in the community with no supervision required mostly. And there are some problems like with impulse control, and he has low self-esteem, and it can be associated with conduct disorder and substance disorder and ADHD. These are the things that can be uh, coming in the future of a patient suffering from the mild intellectual disability. Now, the someone who has moderate intellectual disability, they can have academic skills till second grade. They can get and they manage the daily living activities, and they can work in the sheltered workshops, and they live in residential communities, and they have a problem and they have difficulties conforming to the social norms. Like people with Down syndrome, they are very much associated with Alzheimer's disease. And next is our severe and profound. Severe, we can say severe is I would say 20 to 35, and very profound is less than 20. And so they have no speech, they have very limited abilities, they cannot manage self-care, and they require supervision in day-to-day activities, and they require care. Now what we can do for these people, we can, with intellectual disability, we go for physical examination to see if they have done any harm, or there is any disorder associated that can be treated, or there is any injury. And how we gonna diagnose it prenatally. If there is any chromosomal abnormalities or anything, we'll do mainly amniocentesis, and it will reveal the chromosomal abnormalities associated with high risk pregnancy. And we can treat the patient we can treat the mother who's preconception with genetic counseling. So genetic counseling, so that we can avoid pregnancy in the disease that can lead to the profound disorders being transferred to the next generation. And the other thing that we can do to prevent is we can do good prenatal care, and we can provide good environment to prevent the exposure to any toxins, and to provide newborn with all the care that's required. And if there is any associated medical condition associated with it, what we can do, we can improve the cognitive and adaptive health. We can provide special education techniques that can improve the level of functioning. We can guide them behaviorally, and we can promote self-esteem in such patients, and so they have better emotional quotient with them. And it can present with it can be differentiated from an autism spectrum disorder, because they are very specific, that we'll learn later. And it can be differentiated from borderline intellectual functioning, like patient who have IQ more than 70 to 100. So that is the main differentiation that we have to do to diagnose intellectual disability. Now this was something which is very common. Now we come to the learning disorders. Now learning disorders are mainly caused by not caused, I would say the learning achievements in specific areas that is substantially below the expectation, given the patient's age, intelligence and sensory abilities, and the educational experience. That is that will point towards the learning disorder. So what are the different type of learning disorders? It can be reading disorder, which is the most common. Then there can be mathematics disorder, and then there can be disorder of the written expression. So what are the risks for learning disorders? So it can be due to certain medical conditions like cerebral palsy, or there is any you know substance induced condition with learning disorders, like mother has been having alcohol while she was pregnant, and that lead to fetal alcohol syndrome. And that we have the lead poisoning, living in the old houses built in 1970s with lead you know flaking out of the walls. And so what are the presenting symptoms in such children? So it is around they will present around in when they are in elementary school. They have perceptual motor problems, and associated conduct disorder or oppositional defiant disorder. They have poor self-esteem. They have social immaturity, and it usually leads to social immaturity and school failure, and there will be disturbances in the behavior that will be reported. So how can we test the learning disorder? We can first do IQ testing. We can see the academic achievements. And how can we treat it? We can have a special education to ensure that they can learn with their speed and environment, and that will maximize the skills in the area they are deficient. And we can counsel the patients and the family, so that that will help them to improve their self-esteem, their social behavior, and that will also help in proper family functioning. So this is very important, learning disorder, because it's not diagnosed that easily sometimes, not because not all people are very aware of such disorders, and the child undergoes tremendous atrocities paving his or her way through the academic expectations that are with the parents and the teachers. So we should be very vigilant for that, especially the school teachers and the parents. They should be be aware of this. So next we come to very important and very close to my heart somewhat, because of some cases that I saw of autism spectrum disorder, and we can see so many television series also being built upon it. So autism spectrum disorder, it is a group of disorder that is characterized by problems with the social interaction. There is problem with social interaction, there is problem with behavior, and there is problem with the language. Now what is the risk factor? Why this is occurring? Because of any CNS damage, and that may have occurred. Some infections, encephalitis, maternal rubella, phenylketonuria, tuberous sclerosis, Fragile X syndrome, perinatally there is anoxia. So this all can lead to the autism spectrum disorder. First, it was also in previous Harrison, it was linked with the mercury-based vaccines. Now, presenting symptoms. The presenting symptoms is 0.08% of general population is the prevalence of it, and it will present mainly more in male than female. And onset occurs around less than 3 years of age. And there, what we will see socially, as told you how socially, we'll see lack of relationship with their peers, and they will not be able to use non-verbal social cues, and that is social symptoms. Then we can see problem with communication, like bizarre use of speech, or there is no speech at all. And then there is behavioral problems like odd perceptions. They want to have very characteristic repetitive activities, and they are very adhered to their purposeless ritual, and they don't like it to be broken. And they can have intellectual disability. In more 2/3 of the patient of ASD, they have intellectual disability. And the physical findings are mainly, we'll see EEG, it will be abnormal, they may have seizures, they may have abnormal brain morphology, and that we can just diagnosed with a history and with any test that's required, particularly to specific condition leading to autism. And we mainly the predictors of the poor outcome are associated intellectual disability, and their failure to develop the speech that's useful. And one fourth of the patient of which are autistic, they develop the seizures. And physically, if we see this patient, they have a very habit of self injuring them, like they will bang their head, they will bite sometimes, that kind of behavior. So how can we treat it? We have to do family counseling, we have to give special education, and if there is severe agitation and very self-destructive behavior that is not controlled with the counseling and with the education and with the environment in the family, then we can go for some newer antipsychotics, like atypical antipsychotics that can be used. So autism, just remember, more in males, present less than 3 years, and they have problem with speech, they have problem with behavior, that is rigid adherence to their ritual, their repeated preoccupation with the repetitive activities, and they have to be given special education, family counseling, and we can see their physical examination with self injuries, head banging, and biting sometimes. Now, next very common is with ADHD. Now, everyone wants to diagnose ADHD, so we have to be very careful with it. I have learned it's mnemonic HIA, that is hyperactivity, impulsivity, and attention is not there, that is inattention. So these symptoms last more than 6 months, and there is interference with the social and academic function in more than two places of, like it can be in family, it can be in the school, or it can be place of worship. So for more than 6 months. Now they are present in the multiple setting that I have already told you. It should be present in more than 2 settings. That's not all 3. Now, what are the risk factors? It can be any CNS pathology, or it can be, sometimes environmental factors, social factors. So we'll not go that deep into it. And family history is very important. If the patient already has a history of ADHD in family and mood and anxiety disorders, there is substance abuse disorders in the family that predispose patient for this. And the onset is mainly when the school will complain, the teachers will complain in parent meeting that he or she does not sit in the class and does not wait for his turn and blurts out the answers, and usually it persists till the adulthood. And in the home setting, the person is not disciplined by the parents, that's very difficult, and there is a lot of hyperactivity involved. So what is the symptoms? The patient will have short span. The problem is their attention span that's why inattention. Attention span is very short. There is constant fidgeting. Their inability to sit through the cartoons or through the meals. They cannot wait in the lines. They have failure to stay quiet or sit in the class. They are disobedient, and they mainly get into peer fights. They have poor academic performance. They are careless, and these things are also can be seen associated problems with it, because they will have so they will be scolded more often. So they have low self-esteem, they'll have mood lability, and they can develop conduct disorder, and they are mostly clumsy, and they can get into drug abuse and school failure, and physical trauma can also occur if they are very impulsive. Now, physically, if we examine the patient, we'll see some motor problems, some poor coordination is present. So I will diagnose first. We'll see for the IQ test and various symptom rating scales which are used by parents and the teachers. And Then we use the diagnostic criteria, and treatment is mainly we have to see what are the symptoms before starting the treatment. Psychologically, social, and educational intervention, these three things should be taken care of to add the structure and stability to the home and school environment. So specialized education technique we can use, and that will include various multiple sensory modalities for teaching, and instructions will be very short and they will be repeated frequently, and there will be immediate reinforcement for learning, and that will minimize the distraction in the classroom. Now pharmacotherapy is using stimulants like methylphenidate, using dextroamphetamine, and non-stimulants are also there nowadays, atomoxetine, and these have effectiveness in decreasing the hyperactivity, inattention, and the impulsivity. And the other medication, if they are required along, can be antidepressants that can be added, and clonidine alpha agonist that can also be added into it. So these are all the questions about the drugs use. Then is very important topic, that is the conduct disorder. So conduct disorder is like there is a violation more than 6 months in with aggression, with property destruction, with deceitfulness, and breaking the rules. And it is mainly affected due to short temperament, stressful family and school environments in the school age children, especially more in males, and it can lead to antisocial personality disorder in future. And the patient may have history of antisocial personality disorder in their family, or conduct disorder, mood disorders, or substance related disorder. So mainly these conduct disorder mainly occurs in the late childhood. It presents with our early adolescence, we can say, and it can present as bullying and fighting, the cruel towards the animal, and there is vandalism, there fire setting, they are robbing, and they are breaking school properties. And the complication is mainly what can lead to it is substance related disorder and school failure, and it can lead into the very important antisocial personality disorder, and various depression disorders. Patient may start using substance. So how are we gonna treat it? So we have to first of all identify a healthy group and role models. Okay, by providing him or her with the sport programs, or we can other programs that can be provided, and there that will give the structured living set to the patient, and that will place value on group identification and why cooperation is useful in the group. And normally if we punish these people or these children, or try to threaten them, that won't be very effective. So we have to give them a community environment, why it's important, and make them appreciate the cooperation and group identification as the priority, so they see themselves as a part of community, not against it. Now something called oppositional defiant disorder is there. In this there is a pattern. For at least 6 months the patient is hostile. He has defined behavior towards the adults, and he will have temper outburst, and he very specific, he'll be very vindictive, and he'll be annoyed, and he's not destructing any property like conduct disorder, but he'll be very vindictive and very hostile towards the in the school setting as well as in the home setting. And it is due to high reactivity and motor behavior, due to high temperament, and what it will usually also present in early adolescence mainly, and it will be associated with any family conflict and school failure, or any substance use or ADHD in the family. And the mainly the outcome that we are afraid of oppositional defiant disorder, it will be conduct disorder. So patient, we normally advise the patient to spend time interacting with their peers, and to reward them, use positive enforcement for their good behavior, and not to just go punish them and give them negative reinforcement, but positive reinforcement with reward for better behavior. And we can try to build a community around further and make them appreciate the value of the community. Now, other thing very important is childhood enuresis, which is characterized mainly with repeated voiding of urine in patient's cloth or bed in the child more than or equal to 5 years of age. So any risk can be any, like in psychological stress or family history is there of enuresis. There is UTI, and it is more common in boys. And like patient, they will have, some are dry during the daytime, but they are wet by in the night in the bed. And it also, I told you previously that the patient may start regressing and show bedwetting when they're going through stressful situation like divorce in the house. So what we can do, we'll do toilet training, we'll avoid fluid restriction, we'll avoid large amount of fluids and do fluid restriction before going to bed. And we'll, in case we use bed alarm therapy, which is like whenever the patient pass urine in the bed, it gets in contact with the alarm and it rings and it gives the negative reinforcement and the embarrassment. So the patient is very much take more care that he or she doesn't wet the bed. And there are some drugs, imipramine, that is a TCA, and a desmopressin, which is a adenopressin. And desmopressin is a analog of a drug, and that will prevent that cause water absorption and less urine pass out. So that will also help to keep the patient dry. So imipramine and desmopressin. Now, other very important thing about childhood that we see is Tourette disorder. Now, Tourette is mainly presents with motor tics or the vocal tics. So it has some family history with ADHD or OCD, and it is mainly common in males. And around 7 years of age, the patient motor tics are mainly like twitching of the face, trunk and extremities, and there may be spinning, touching behavior associated. Vocal tic is the patient is grunting, or coprolalia. Coprolalia is speaking bad words, cursing, he keeps on cursing. And it can be lifelong, and it can have remission and can be exacerbated in certain environment and conditions. Sorry. So treatment is mainly antipsychotic drugs, that is we can give haloperidol, olanzapine atypical, risperidone, and we can also go for pimozide, and clonidine and clonazepam are also used sometimes. So next video will be on the psychiatry part 2.